Hello and good afternoon, everyone. Welcome to NCSL's Opioid Policy Fellows' second webinar, The Role of Peer Recovery Models. My name is Tammy Jo Musgraves, Policy Specialist with NCSL, and I'll be moderating today's webinar. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions and answer any questions in the chat box, which is in the lower left-hand part of your screen. To begin building some comfortability with the chat function and to also learn who's on the line today, I encourage you to type in the state from where you are calling now. I want to briefly mention the resources. Above the presentation, you will see a couple tabs with one of them labeled Resources. Here you can find and download a PDF version of the PowerPoint. Another tab is labeled Speaker, where you can read about each speaker. You can also access these tabs at any time during the presentation. Today's webinar is being recorded and will be available to all fellows within the week. Today's webinar, we have an opportunity to learn about two different state approaches to utilizing peer recovery support models within emergency departments. We will hear from Michelle Harder, Community Liaison and Consultation Manager with the Anchor Recovery Community Centers, and Karen Hartwell, Associate Professor at the Medical University of South Carolina. After the presentation, we will invite and encourage all of you to ask questions and share any challenges or successes that you've seen in your state by typing into that chat box. Before we begin, we will review a few NCSL resources and take a quick anonymous virtual check-in to gauge the level of comfort with the subjects before moving into our main presentation. NCSL would like to thank the National Center for Injury Prevention and Control within the Centers for Disease Control and Prevention for their support of today's webinar, as well as the Opioid Policy Fellows Program. The Opioid Policy Fellow is possible because of grant funding through the National Center for Injury Prevention and Control. A few reminders for everyone. As you know, we have postponed our May in-person meeting. Thank you for filling out the survey Jessica sent out regarding your availability this fall. We hope to follow up shortly with dates so you can save them on your calendars. I would also like to remind everyone that technical assistance is available to you from NCSL. We have responded to many requests from the first meeting and our first webinar, but are always here to assist with informational memos and connecting you with national experts, other legislators, and state officials. Please don't hesitate to reach out to myself or Charlie with any questions you have. NCSL has also been paying close attention to COVID-19, particularly its implications for state legislatures. As a whole organization, we have our coronavirus resources for state legislators and legislative staff consolidated on one webpage, which links to various program-specific information and is continuously adding new resources and publications as they become available. As you know, there really isn't an area being untouched by everything that's going on, so we've tried to keep all of the intersecting information in one place. There are tabs and links for each program, also information through podcasts, webinars, and some resources to share with your constituents. The link to the webpage can be found on this slide, the previous slide, and again at the end of today's presentation. Our health program has a number of resources available to you. Web pages on state quarantine and isolation statutes and state laws on paid sick leave. A few blogs on health workforce and insurance coverage and costs related to COVID-19 testing and treatment. We're also tracking all introduced and enacted legislation related to COVID-19 on State Action webpage. We've seen at least 35 states, DC, Guam, and Puerto Rico introduce legislation supporting state actions responding to COVID-19, and at least 32 states, DC, and Puerto Rico have enacted legislation. You can search these bills by text, state, or statute. Please feel free to reach out to Tara, Kate, or Noah for any questions on state response to COVID-19. They're tracking state legislation and updating the state action page daily. As well, during COVID-19, we're collecting a list of legislators leading or are a part of a COVID-19 task force. And if any of the fellows or states on the line have task forces, please send a note or put in the chat box to Tara Johnson. While peer recovery programs and models aren't a specific area our team is currently tracking, we often receive questions from our members and our fellow cohorts about how these models work and how states are utilizing peers to connect their constituents with services and supports. Peer recovery related legislation in 2020 so far, we have seen 25 bills introduced across 12 states, and 5 bills have been enacted in 3 states related to peer recovery coaches, groups, or supports. Because we know many state legislatures are on a recess due to COVID-19, we've also included numbers from 2019. During 2019, we saw 76 bills introduced across 19 states, and 18 bills were enacted in 8 states. These bills range in their content, but common themes that are included are requirements to have a peer recovery coach on behavioral health or maternal child health task forces, embedding peers in law enforcement diversion programs, and appropriation bills. Finally, we want to highlight all the great work that your fellows have been doing throughout 2020 so far. Altogether, you have introduced over just 400 bills. To follow your colleagues and see what they are introducing in their state, please look at the NCSL Injury Prevention and SUD database. All right, next we will move to a few survey questions before hearing from our speakers. The survey questions will become available through a pop-up screen. And your first question is, did you follow up on an action plan step that you wrote down on your action plan? You can answer yes, partially, or not yet. All right, sorry, I was waiting for that to come in. It looks like here we have some partially and not quite yet. So that's all right. It looks like we still have plenty of time within our session to look at some of those. And if you have questions as you're going through your action plans, again, please reach out to us. Second question we have for you. How many of you shared resources related to the first meeting, first webinar, or NCSL resources with a colleague? And I apologize, I think it says check all that apply, but you can check 2. So yes, in conversation with legislators and legislative staff. Yes, in conversation with partners such as the Department of Health, Medicaid, or private sector. Yes, while discussing proposed legislation. And yes, such as slides or handouts, or no. All right, and as your answers are coming in here, it looks like a really great mixture. I would say that the majority have in conversation with legislators and legislative staff, so that's wonderful. All right. Our third question for you, have you introduced legislation related to peer recovery models or felt more informed on other legislators' proposed legislation? Again, check two that might apply. Yes, I have introduced legislation. Yes, I felt more informed on peer support models so far in session. No, I have not introduced legislation, or there has not been legislation introduced on peer recovery models yet, or not applicable, maybe due to temporary suspended sessions. All right, and it looks like we're seeing a pretty good mixture. It looks like a few folks have introduced some legislation, a few have felt a little bit more informed about it, and then about 20% or so not applicable. So it's pretty good. All right, and then your last question here, how would you rate your understanding of peer recovery support models? Very limited, fair, adequate, good, or expert? Oh, good. It looks like so far we're seeing a pretty good mixture, some pretty good understanding, a little bit limited. Well, good. Hopefully today's presentation will be able to either help answer some questions you might have or give you a deeper, better understanding of these models, or if you are on that good to expert level, we can really foster some deeper discussion here. My information is here if you have any questions. It's also at the end of the presentation. But without further ado, I think we will go ahead and pass it over to our first speaker. We will hear from Michelle Harder with Anchor Recovery Community Centers out of Rhode Island. Michelle, whenever you're ready. And Michelle, I'm not sure if you're on mute. All right, well, I think while we try and reach Michelle here, we will jump down, go a little bit out of order. And so, Karen, I hope you are ready. I'm going to kind of put you on the spot a little bit early. So we will have Karen Hartwell, Associate Professor at the Medical University of South Carolina, to discuss her peer recovery model. Karen, whenever you're ready.
Okay, thank you so much. It's certainly my pleasure to speak with all of you from the coast of South Carolina, and appreciate your taking time out today. And I'm delighted to fill you in on what we have, one of the initiatives that we have done in South Carolina in regard to the opioid epidemic. I'm an addiction psychiatrist here at the Medical University, and I have no conflicts of interest to declare in regard to this presentation. Of course, right now we're all consumed with a COVID-19 epidemic and all the implications for across the country, but it's important to remember that the opioid epidemic is continuing unabated in the midst of the COVID epidemic. And you can see this based on this map of the United States. This is looking at differences in of overdose deaths between 2017 and 2018. The darker states, which sadly includes my own, there was an increase in deaths. The middle blue color is similar overdose deaths, and the lighter states show that there was some progress, but you can see there's still a lot of work to be done. And the emergency room departments are really at the front line of the opioid epidemic as people come in with overdoses and a variety of opioid-related causes. And you can see here on the graph on the top there, the increase in the opioid-related ED visits. They've actually increased over 100% between 2014 and 2018. And sadly, of individuals who are resuscitated by EMS with naloxone, 10% of these individuals die within the subsequent year. So one of the things that's happened in the treatment of substance use disorders, there's been a shift from an acute care model from back in the early 90s and 80s when we used to bring people into the hospital for a 28-day inpatient stay to more of an outpatient model with a continuum of care from everywhere to counseling, residential services out, and all the way to additional services as needed. And peer support is a very valuable addition to this menu. And recovery coaches have experiential knowledge in terms of their own recovery, in terms of how did they get sober and how are they, the other important pieces, how do you stay sober, and then begin to being able to assist others in facilitating and supporting long-term recovery. And I know Michelle will be covering this in detail in her presentation. Now, researching peer recovery support services is challenging because peer supports are taking place in a wide variety of settings. There's different definitions, different services, different patient populations, and frequently there's a lack of control groups in this research. However, despite this mixed result, a recent systematic review indicates that peer support across a variety of settings reduced illicit substance use and relapse rates, hooray, increased treatment retention and treatment satisfaction, as well as improving relationships. One of the tools that's utilized widely across the United States is SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. This is an evidence-based practice that's used to identify individuals who are using substances in a risky way, as well as those who have a substance use abuse or dependence diagnosis. So the screening's done utilizing screening tools and a thoughtful brief intervention where people are given feedback about the screening and advice, and then for those who need additional assessment and treatment, referring them and facilitating ongoing treatment. So what we've done here at the Medical University is we've put these things together. We've used both peers and SBIRT, and what we've done is we've integrated peers, which we call patient navigators, in our system, to integrating SBIRT into the emergency department. And it's certainly very cost effective. Our patients like it, and it also frees up other valuable staff to be doing the other necessary things to do in the emergency department. So our peers have specialized training and motivation, interviewing, and skills. Some are employed and supervised by the hospital, or some hospitals that we've worked with have chosen to contract them with an outside peers agency. The time varies in terms of how much time is covered in the ED. In our ER, we have peers in the ED from 6:30 in the morning and 2 in the morning, because we've noticed that the majority of people with substance use disorders are tending to come in during the evening shift. So all individuals coming into the ED are screened and triaged by a nurse with a few screening questions. If they're positive, the peer navigator is notified, who reviews the record, meets with a peer. The peers meet with the patient. They do a more thorough screening using the drug abuse screening tool, and the alcohol use disorder identification test. And then they provide feedback. They begin to discuss doing some interventions, some recommendations, some interventions. And then they, together with the patient, develop a plan and schedule additional treatment as needed. So this is what we do in terms of what if in that screening they diagnose someone who's using opioids in a risky way, or they suspect that the individual does have an opioid use disorder, in which case we build on some additional work. Dr. Gail D'Onofrio at Yale did a very interesting study, and it was published in 2015 in JAMA. She looked at 3 different groups. She had about 330 people in the study. They were randomized to either just a screening, a brief screening and referral to treatment, a true expert with the addition that they really facilitated that next day appointment, to the expert with facilitated referral with the addition of initiating buprenorphine in the ED. And this is what she found. So on the x-axis here, you can see the 3 groups: referral, brief intervention, and the group that was started on buprenorphine. And on the y-axis is the proportion of individuals who were still in treatment at 30 days. And you can see that almost 80% of the people who received buprenorphine in the ED were still in treatment in 30 days. But one of the things they did when they initiated buprenorphine, they also had an arrangement for the individual to be seen the next day for follow-up. So there was follow-up within 24 hours. Somehow I lost there. Also looking at this group, the part of the legend got lost here in translation, but the red line are the individuals who received ED-initiated buprenorphine. And you can see here the 30-day follow-up, they were much less likely to be using opioids, illicit opioids. And another important cost saving that was found in this study is looking at, in that subsequent 30 days, how many of these individuals required inpatient services of some sort. And you can see, compared to the referral and brief intervention, the buprenorphine group required significantly less hospital admissions. In an additional study, this was done by Dr. DeLaroche and colleagues in Boston, and they looked at over 1,700 individuals who'd had a non-fatal overdose, and then followed them all over the next year looking at medical records. And the very top line, so on the left is you can see the x-axis on both graphs is the month from the overdose, and on the y-axis, the first graph on the left is all-cause mortality. So it's going from 0 to 6% there. And you can see as the months progress, that very top line that looks like a staircase are the number of all-cause mortality. So 5% of this group was dead within a year. And the bottom lines are those who received medication, either methadone, buprenorphine, or naltrexone, which is an opioid blocker. The authors did comment there weren't enough people on naltrexone to really just to draw any conclusions, but you can see the other 2 therapies, there was a difference in terms of reducing the number of deaths in general. And on the right-hand side is that same curve, but this is opioid-related deaths. So both medications, the buprenorphine and the methadone, significantly reduced mortality over the subsequent year. So this is what we do in our program. Individuals who screen positive for opioids and they're motivated for treatment, the patient navigator notifies the ER physician, who then assesses the patient. They diagnose an opioid use disorder, and the person is willing to engage in treatment. They'll go ahead and give that first dose of buprenorphine in the ER. I'm commenting there about pregnancy because even if a woman is pregnant, there's no reason for us not to go ahead and initiate therapy, both for the mom and the baby's sake. You'll see in that next little oval, there's cows. Due to the unique peculiarities of buprenorphine, it needs to be started when the individual is in some degree in withdrawal. And COWS stands for the Clinical Opioid Withdrawal Scale. And if you want to ask me more about this, we can certainly do that during the Q&A, or you're welcome to contact me offline. So everything's ready to go. The nurse administers the first dose and monitor the patient, see how they're doing. And then the peer helps arrange the next day fast-track appointment for follow-up. And we do have the ability to provide bus tickets in the event that someone does not have the ability to get to that appointment. There are a few exclusions there that you can read, but one of the things I just wanted you to notice that if people don't live within the county, they're not usually initiating buprenorphine because you have to have that fast track site in order for the program to be successful. So what's been our experience? Well, I thought I'd like to let you know how this all got started. It actually got started by a group of legislators just like you who held a variety of town meetings across the state in conjunction with the director of our state agency. And okay. In conjunction with the director of our state agency, the South Carolina Department of Alcohol and Other Drug Abuse Services, as well as some members of our faculty. And out of these town meetings, the legislature, together with leaders in the state, were saying, what can we do? And then our legislature actually gave an appropriation act for us to expand MAT services to treat opioid use disorders and support MAT interventions, including in the ED. Another additional caveat was South Carolina chose to use some of the state opioid response funds from SAMHSA in order to be able to continue to fund individuals who are uninsured and lacked resources, because that is another important component. So this is how we started. We initially started in the counties with the highest opioid overdose deaths, which were along the coast. Then we began to expand by really the areas of at highest risk. So we are now in 5 ERs and have plans to expand into additional EDs this year. So here's our cumulative data. You can see that over the approximate past 2 years, we've screened over 17,000 patients in the ED. We've identified over 7,000 with an SUD. We've diagnosed almost 2,000 individuals with an opioid use disorder, have inducted about 500 on buprenorphine, and you can see we've given out over 600 naloxone rescue kits. This is on the y-axis here is actually the number of patients inducted. The x-axis is by month, and you can just see by site the fluctuation in terms of those inductions. With the darkest blue there is MUSC, my site, that was the first one to start. And you can see over time, we didn't start everybody at once as other EDs began to become online. So how are we doing in terms of follow-up? We're doing pretty well. You can see almost 80% of individuals that we start on buprenorphine make that first appointment 24 hours later. And so we're very pleased about that. And where it's lower, it gives us an opportunity to work with them. And in terms of retention and treatment, you can see about half of the individuals are retained in treatment after 30 days, but there is some variation. So this would give us the opportunity to work with those sites with lower retention on strategies to keep people in treatment. There are a number of limitations and challenges, as you can imagine. There's differences in treatment philosophies. There's some substance treatment places that are very focused on not using medication. So it's really caused a shift in terms of being able to accept that people can be in recovery and on medication for it. One of the challenges that people encounter is you have to have these referral resources. So if you initiate buprenorphine, you have a place to send individuals. And there's also some federal regulations around the prescribing of buprenorphine that can be a challenge, but not insurmountable. And also we're all dealing with COVID, as well as we want to look at funding and sustainability. So what are we doing now in the midst of the COVID epidemic? The peers are now delivering their services completely remotely in our 5 sites, either using a telemedicine platform that particular hospital is using or via the phone. And also in the midst of the epidemic, the DEA, in conjunction with SAMHSA, now is allowing practitioners to initiate buprenorphine via telemedicine, which we couldn't do in the past based on the Ryan-Haight Act. So what about sustainability? This is a study that was done by Dr. Kit Sampson here at MUSC. She looked over a 2-year period of individuals who had seen an NED across the state who had had at least 2 opioid related visits. And you can get a look at this group. It's fairly equal as far as gender, but I want you to take note at how young this population is. Over 50% of them are under the age of 40 and 80% under the age of 50, with a significant number who are uninsured or on Medicaid. Sadly, about 10% of these individuals died within this time period. And without intervention, there were on average about 5 additional ED visits at a cost of $52,000. There is evidence that ESPERT results in cost savings. The box on the left is a study looking at disabled Medicaid patients seen in the emergency room and screened for alcohol use disorders and given a screening and brief intervention. It actually resulted in significant cost savings there, as you can see, and most of that came by reducing the number of inpatient admissions. And on the right is looking at another, again at alcohol, looking at substantial reductions by reducing continued re-injuries and ED visits. So trauma centers do recommend national implementation of ESPERT. We have done an initial cost analysis. This is ongoing, but I just wanted to show you a little bit about what we've gleaned so far. We gathered pilot data on the first 37 patients that we've initiated on MAT and could follow them out for at least a year. And in this small group, we found a 23% reduction in annualized events with an average savings of over $8,000 with an almost 30% reduction in charges. Remembering back to that graph that I showed you a few slides ago, without intervention, it would continue to be costly from year to year. So one of the things, though, we do need to be thinking about is a high proportion of uninsured and Medicaid may require some mixed approach for funding in the future. You'd like to know some of the models that we have looked at for sustainability. You can read them here: contributions from treatment centers, insurance providers, hospital-based incentives, because anytime we can keep people out of the ED, in my office, it saves a significant amount of money. Also, peer services are very poorly reimbursed. So we've actually approached our DHSS about increasing the reimbursement for peers to be comparable to our neighbor state, Georgia. At present, the reimbursement rates are so low that it's not worth the cost of the billing for my particular organization. We've also looked at expanding peer services to the inpatient unit, as well as considering using a central bank of peers to a number of EDs with telemedicine. There are a number of steps that would need to take place in order for this to be replicated, including, of course, you'd have to have the funding and the buy-in from the hospital, the establishment of the fast-track sites. In the absence of Medicaid expansion or insurance, you'd have to have at least one site in the county that would be able to access funds to carry out MAT services, including a relationship with a pharmacy. The hospital pharmacy and therapeutics committee needs to get involved, and then all the steps in terms of training, the importance of offering waiver training to ED staff, the hiring and training of peers. We have used Marla Oros from Group Mosaic very successfully. Then the hospital system needs to build notes and the capacity to build, and you certainly want to collect some data. One of the things that our ED staff was really concerned about was, wow, all these people are going to be coming back into the ED all the time. And actually, we found in that dark wedge are the people for whom we initiated buprenorphine. Only 11% of them showed back up in the ED compared to 90% without. And also, there was concern that there was going to be an incredible, overwhelming demand. And that was indeed not the case. It's been pretty constant. So our ED docs, from initially being reluctant, now are very pleased with the work that we've done, and we're stopping those repeated ED visits. And here's a list of my collaborators that you can read here. And of course, special thanks to all of our EDs and to all of our peers.
Wonderful. Thank you so much, Karen, for that presentation. I know that I have a few questions, and I'm sure others do, but we will save that for after we hear from Michelle. However, I would encourage all of you on the line that as you have questions to type them into that audience chat box, and we'll help capture them here after the next presentation for discussion. So with that, Michelle, if you are on the line, I will hand it over to you.
Thank you so much. And yes, Tammy Jo, I am actually on the line. Good afternoon, everyone. Sorry for the technical difficulties on my end. Karen, thank you for your amazing presentation. And I'll make a couple of comments about it as we go through our ED presentation. I really want to start with Anchor Recovery Community Centers being the premier recovery community center in the state of Rhode Island, and being the first to institute peer recovery supports back in 2010. So let's talk about what a peer recovery specialist is. An individual or family member who has lived experience with mental health and or addiction to alcohol and other drugs. And we do include alcohol and opioids. We feel that we're fighting a total addiction battle here in Rhode Island and not just an opioid battle. A peer has completed formal training and provides one-on-one strength-based support to peers in recovery, and that's something that we do on a daily basis. Next slide, please. Okay, so what is formal training? So I know that every state is different, but in Rhode Island, we have really been fast forwarding our curriculum for peers for mental health and substance use, and are turning to a community health worker model, which is going to take some time to get into play. And certainly with COVID-19 will take way longer than we anticipated it. But in Rhode Island, our peers must enroll in a 30-hour peer integrated training, including all the domains of advocacy, wellness and recovery, mentoring, and education. Complete 16 hours of ethics training. And then after they have completed the 46 hours of mandatory training, they must accumulate 500 hours of supervised training on the job, either with a paid internship or as an employee or as a volunteer. Once those 500 hours are established, then they can then make an appointment to sit for the peer recovery specialist exam and become certified. Next slide, please. Okay. Anchor currently has 2 recovery centers. Both are extremely busy, one in downtown Providence and one in Warwick. We also have grown from our kind of centralized recovery center. We've added legs, if you will. The Anchor Emergency Department, the first of its kind in the country, award-winning on a national level. Our Anchor More program, which is a mobile outreach recovery efforts. We are in the Department of Corrections. We have a Safe Stations program modeled after the Safe Stations in Manchester, New Hampshire. And we also have the Jim Gillen Teen Center, which is a brand new facility that we utilize specifically for teens that are trying to find recovery. And we take those individuals from our Anchor Recovery High School. Okay, some key services that we use here are peer recovery supports, obviously. That's our motivating factor. We have employment services, tremendous volunteer opportunities, recovery-focused events and activities that include the family members of people in recovery, because we really want to promote the fact that even though, yes, people are dying, lesser amounts in Rhode Island right now from opioids, fentanyl, et cetera, that the families can be involved in not only the despair of addiction, but also in the recovery and what comes with, the amazing life that you get when you enter into recovery. We also offer a lot of wellness activities, and they're kind of going towards the holistic model these days. We're offering Reiki healing and guided meditations and yoga, etc. Hopefully that seems to be the way things are going right now. So we'll see if that keeps up. I think that given what we're going through right now, that's probably a great possibility. You can see the vast array of weekly groups that we hold. All of them are exceptionally well attended. I will put in here that during the COVID-19 pandemic, as Karen talked about, our recovery coaches are doing everything either by telephone, by virtual meetings, through Zoom, and we're just unable at this point to be able to meet one-on-one with our community. It's been difficult, but as we have gotten into this each day, it's become easier and easier for people to understand the technology, to be able to connect with it, to understand that they can do it on their phones. And now our daily meetings are all done that way, and people are finding them to be such a comfort in this time of complete isolation for people that are used to, seeing faces on a daily basis. In 2014, and I really want to talk mostly about Anchor ED, we launched this through a collaboration with Jim Gillen, our former director at Anchor, who passed away 5 years ago from cancer, and the former director of our Department of Behavioral Health, Rebecca Boss. It was really a conversation between the two of them over coffee one morning, and it was, how can we meet people where they're at? How can we get to them before they're, wandering the streets or becoming part of the homeless community? And they came up with the idea is, maybe if we could meet overdose victims in the emergency rooms. And so we started very slowly in one hospital, the largest hospital in Rhode Island, and we had no money. I want to put that right out there. Don't let money stop you from at least trying to establish an ED program. Find a champion in the hospital that will help you work through that issue. They're very willing. As Karen said, at first they were, really iffy, the ED docs, the nurse directors, about moving forward with this kind of a program and letting people with lived experience into their emergency rooms during, highly traumatic incidents. And over time, and it took a lot of education and a lot of conversation one-on-one and with, groups in the morning at their morning check-ins to say, listen, we're here to help you, and we've developed an amazing reputation with our recovery coaches in that we were able to very easily go from an in-person product to a complete phone interaction during this COVID-19. We're able to FaceTime with some folks and telephonically with other folks, and the response has been overwhelmingly amazing. Although I will say that in Rhode Island, our overdoses have decreased during COVID-19. Again, we're a nationally recognized program highlighted on PBS, on the national news, recipient of an innovation award at Addiction Policy Forum. We've provided consultation on Anchor ED and Anchor's recovery support services all over the world, Vietnam being, one of the ones that we're most proud of. We've responded to over 5,000 overdose calls since 2014. That's coming from the smallest state in the union, and supported 82% of patients to accept treatment and or recovery-based referrals. In other words, finding shelter or other means of health, home, community, and purpose until we could get them into an available bed in the state of Rhode Island. Again, find yourself a hospital champion, somebody that will work with you. That is one of the greatest tips that I can give to anybody about this program. I think that at this point in time, what I want to say is that because this program is now funded through our Department of Behavioral Health as part of the overall addiction epidemic response for our state, we are provided funds from our Department of Behavioral Health. We do not bill for emergency room related recovery coach calls, peer specialist calls. Obviously, we'd be, kind of double dipping if we did that. But to go back to starting in that first hospital, we started from 7 p.m. on a Friday night till 8 a.m. in the morning on Monday, and it was hugely successful to the point where the hospital emergency room staff started calling us during the week. We responded without that being in our contract, and it really took off from there. And obviously, every hospital in the state wanted to do it. We had to push a couple of the privatized hospitals to jump on board, but with a little bit of persuasion from the state, they did so, and they're all extremely happy that they did that at this point in time. Again, we don't look just at opioids. We look at everything that comes through the door. We do see a lot of alcohol, and actually, as the decline in overdoses through the COVID-19 pandemic, we see more and more hospitals every day. Community partners in this kind of a situation are really essential. Very quickly, we have our Anchor Safe Stations. Again, molded after the Manchester, New Hampshire Safe Stations. We operate in Providence, the city of Providence only. There are other agencies that operate in other fire stations throughout the state. You can walk into any fire station in the city of Providence and immediately be connected after assessment by an EMT to a recovery coach that can put you into treatment or a facility, which we call BH Link, which will further assess them and hold them until some bed availability. I've spoken a little bit about the Jim Gillen Teen Center. It's something that is up and coming across the country with alternative peer groups for kids. As you can see from the slide, we do quite a few things with the kids, and it gives them an opportunity to have a safe space after school and on the weekends. Highly successful, and we're very happy to, talk to anybody who wants to figure out that whole issue for their state as well. Okay, so one of the things that we definitely should talk about is we did have some, we were able to coordinate with every insurance company in Rhode Island to provide peer billing for peer recovery supports, coverage for peer recovery supports. So we started with United Healthcare, neighborhood health through our affordable healthcare program here in Rhode Island several years ago in late 2014. And as that became more and more successful, other companies were willing to jump on the bandwagon, as it were. The first commercial health insurance entity that we had was Blue Cross Blue Shield. And I'll be honest with you, it was the last that we thought would help us. But they did, and they have seen amazing results from this. So what they're saying is that participants' medical and pharmacy costs have decreased 12% following initial program engagement. I mean, that's amazing in and of itself. And those numbers continue to grow, if you will, from the longer that people are sustaining their recovery. And we find as well that people that are receiving buprenorphine in our hospitals, we are in a pilot program right now with Rhode Island Hospital, which is the biggest hospital, to provide on-site buprenorphine inductions. It's working well. It's also being done in conjunction with another research study that is talking about the amount of kind of using a placebo effect. Some patients are sent to a recovery coach, and some patients are sent to a social worker, and we're looking at the efficacy of both of those types of programs to see which is more beneficial for our patients. Peer recovery is predicted to reduce long-term costs. As you can see, this participants admitted to treatment cost on an average $2,800 more than participants that are not connected. They expect that predicting in the regression model a 67% long-term decrease. That's amazing, and I don't think that we see that in a lot of programs, health-based programs, and to be able to see those kinds of costs, hopefully will give peer recovery supports some of the evidence that we're going to need to make this an evidence-based practice. So I urge you that if you're trying to work with health insurance companies to get billing for your recovery support services or learn how to do that, contact us. We're more than happy to help you with that, and see if we can't, assist you in filling some of those cost voids that we all see when we're dealing in this uncharted territory. That's about what I have. I'm hoping that, I didn't want to keep talking to everybody in case there was time for a lot of questions. I know sometimes that happens for me. So thank you, Tammy Jo. Hopefully I was able to answer some questions. And if there's more, please let me know.
Wonderful. Thank you so much, Michelle, for that wonderful presentation. And again, Karen, for you. I think that was some really good information and some really good data. I do know that we have a few questions that have come in. I will also acknowledge that we are 4 to the hour. So we will stay on a little bit. Please feel free to stay on if you are able to. Otherwise, this is also being recorded, and we will make sure that all of you receive the recording. And if we don't get to all of your questions, we will answer them through email. So I was originally going to go with our first question, but I believe we're hoping he gets audio back. So I'm going to jump to our second question. And I think this could be really Karen or Michelle, either or both of you. We have a question that says, do you see emergency department patients who have had street buprenorphine when they come in, and how do you treat those folks? And are they resistant to a more formalized prescription or medical treatment plan?
Hey, this is Karen. I'll jump in here. It is not at all uncommon for people to have tried buprenorphine from the street. But in my area, one tab of a typical buprenorphine dose costs anywhere from $10 to $25, opposed to if I prescribe it, even if you don't have any insurance. At Costco, it's fairly inexpensive, and it's, at max would probably be $1.50 a tablet. So most of the people who come in are wanting to get off of the street buprenorphine. We want to engage them in treatment. We like to continue the medication. Oftentimes it's underdosed because they can't always get it, and to continue them and to engage them in further treatment services.
And I would add that that's exactly the same type of thing that we see in our EDs, that and it's really kind of the other way around. We see a lot of people that are coming in with methadone that want to get on buprenorphine. And, you know, there's other things that go along with that, you know, going through some withdrawal before we can get on the buprenorphine. And yeah, sometimes they are more resistant to formalized training, medical treatment. But what we also see is that when you engage someone in the emergency rooms that has lived experience, and we can say to people, I know where you've been, I know exactly how you're feeling, I can tell you what's happened to me, and we can get through it together. As people realize that they can build a level of trust with the recovery coaches in the ED, it does make a huge difference. And word travels pretty fast in the community.
Wonderful. Thank you both. So we will jump back to the first question we received. And I think, again, this could go for either speaker. As well, I'm going to call out my colleague, Charlie, and ask if he has anything to add. The question is, what issues are we seeing with drug use and mental health with COVID-19?
Can I jump in on that one? This is Michelle.
Yeah, please, go ahead.
Okay, so we're seeing a lot of increased mental health issues for sure. We're seeing more of the co-occurring types of things. We're also seeing that people are feeling extremely isolated, obviously afraid to leave their houses. If they're in a situation where there's paranoia or schizophrenia, and, you know, they're alone. And so we feel that that connection that our coaches make every day to people that are on our member list is vital. To be able to hear someone on the other end of the phone and know that you're truly not alone in the situation that you're in. And I think, too, that sometimes we have people call 2 and 3 times a day. We had a woman call yesterday after we were on a local television station about the services we're providing, just to hear another voice. And I got chills, you know. She said she suffers from mental health issues and that she wasn't affected by substance use, but that just knowing that there was somebody out there that she could reach out to was, you know, astronomical for her. So yeah, we are seeing a lot more mental health, and we're seeing a lot less overdoses and more types of withdrawal calls, people that are really wanting to get into treatment because they can't get their hands on their drug of choice.
Thanks for that, Michelle. I think that was all great information. I think I would just add that I think we've seen an increase in folks who are concerned about folks who are already living in a bit of isolation, thinking about folks like folks living in nursing homes and that sort of thing.
Mm-hmm.
Right now, they're isolated from their family members. I think we've seen an uptick in interest in terms of suicide prevention. We know that economic hardship can be a risk factor for that, and another mental health problem. So I think folks are starting to look, especially if you know, the economy doesn't rebound quickly after, you know, we all get to go back to the office. I think that we've also seen advisements around things like naloxone distribution to be especially liberal with how we're handing that out, and be sort of innovative in how we're getting that into folks' hands. Different ideas around naloxone distribution, and then just making sure also that folks know that the DEA has recommended month-long prescriptions for buprenorphine, with refills, and there's also authorized things like telemedicine for prescribing of buprenorphine. And there was a webinar I was on a few weeks ago that has some better resources that sum this up a little more coherently, so I'll be sure to share those with you, Senator. And everyone else.
Thank you, Charlie, and thank you, Michelle. We will also, I'll do the shameless plug of also saying that with the NCSL COVID resources, we are focusing on a myriad of issues, and I would say that there will be likely some blogs and podcasts in the future related to mental health, especially as the timeline of this shelter in place is a little unknown. So we do have 2 more questions. Speakers, if you're okay staying on for just a few more minutes here.
Sure.
We do have one related question, and I think even fellows could potentially put in the chat box information around this. A state is seeing their increase in alcohol use during COVID-19. Are other states experiencing this, or what are you seeing around this?
I think here in South Carolina, we certainly have that sense that there's an increase in alcohol use and perhaps an increase in alcohol-related emergency department visits. I'm on the faculty here at MUSC, and one of the residents and I are beginning to track that because it's more anecdotal at this point, but there was some sense that there was an increased number of visits, and also that the blood alcohol levels were higher among those individuals who came into the EDs. How about up there in Rhode Island, Michelle?
So Karen, we're experiencing the same type of thing, and we've always tracked our ED data since day one, and our data collection was very antiquated at that time. Thankfully, we've been able to move forward, but we've always seen a significant amount of alcohol, but that has jumped. I don't know the numbers at this point because we don't have our numbers in for March yet, but I'd be happy to share that with anybody. I just know from speaking with our coaches on a daily basis, and we go through all of the cases that we see in the hospitals the night before at our morning check-in, that we're seeing more and more alcohol. And I know the comment was made that that their blood levels were higher with alcohol as well. So we're experiencing the same type of thing.
Yeah, thank you both so much. I would say anecdotally, I've heard the same as well. I think at least on our end, like you said, Michelle, we don't quite have the data to look at that. But I think if that is something that you all are collecting, I know you said you collect alcohol data as well, and maybe as you have those March numbers, if you'd be willing to share it with me or Charlie, and we could pass that to the fellows here, just to have a sense of kind of what we're seeing during this time.
Yeah, I don't have a problem at all doing that, and naturally they should be ready sometime mid next week because that's when they're due to the Department of Behavioral Health, and I'd be more than happy. We have always shared our data, but we have always kept data on, why the person is coming in, what their age groups are. We have a vast amount of data that we have collected for our ED program, and frankly, that's how we get our money. So to continue the program. So we have some really good data that I think people would be interested in seeing.
Wonderful. Thank you for that. And then we'll do our final question here. And it says, how many staff persons were regularly needed for the weekend support at hospitals, kind of at 8 p.m. on a Friday to an 8 a.m. Monday?
Well, I will tell you that when we first started this, because remember, back in the day, Anchor was a fully volunteer-based community center, and I think our ED recovery coach was maybe the third or fourth person that we had hired. So his name was George, and he was on the entire weekend shift, and there was one person. What we've done since then is we've established a per diem kind of situation, and we have different shifts. We have, like an 8 to 4 shift during the week, and then we have 4 to midnight and midnight to 8 a.m. now. all per diems that are, paid a stipend for that, being on call for that amount of time, and also a stipend for as many calls as they have to go out on during the middle of the night. Our day people are now employed as employees of the Anchor ED program as opposed to a per diem. And we really adjust as to whatever the community is needing at that point in time. So I will tell you that one person grew to 3 people very quickly. If I recall, it was maybe no more than 6 months that happened.
Wonderful. Thank you. Well, I think right now that is all the questions that we have. But again, if you do have more questions for Karen or Michelle, please feel free to send them to Charlie or myself. We'd love to connect you. Thank you, Karen and Michelle, for an excellent presentation and for answering our questions. I'm giving you kind of a virtual clap here. This is a really great way to have a presentation and midday kind of on my Friday. I will say here just a few more reminders again for the fellows. We will let you know shortly about those second in-person meeting dates. We're always here for technical assistance, and please visit our COVID-19 site if you have additional questions. Otherwise, thank you all so much for joining. Stay healthy, and we hope to talk to you all soon.
Thank you, everyone.
Thank you as well.